I've been practicing medicine for over 15 years now, and there's something I see almost every week that really gets my attention. A patient walks into my office, usually somewhere between 45 and 65, and they tell me they're just tired all the time. They laugh it off, make a joke about getting older, and then they pause. There's this look in their eyes, like they're wondering if maybe this isn't just about age after all. What strikes me most is how normal this feels to them initially. They've been pushing through months, sometimes years, of this creeping exhaustion. They wake up tired, they drag themselves through work, they collapse on the couch every evening. But because it happened gradually, because everyone around them is also complaining about being tired, they assume it's just part of life now. The thing is, I see this pattern differently than they do. When someone describes feeling winded walking upstairs they used to climb easily, when they talk about needing a nap every afternoon when they never napped before, when they mention that their usual weekend activities feel overwhelming now, these aren't just age markers. These can be early signals that the cardiovascular system is working harder than it should be. It's worth paying attention to how often this comes up in conversations with friends and family. The fatigue we're talking about here isn't the temporary tiredness after a busy week or a poor night's sleep. It's a persistent, unexplained exhaustion that doesn't improve with rest and seems disproportionate to activity level. What happens in the body during this time is actually quite complex. The heart might be struggling to pump blood efficiently, but not in a way that causes obvious chest pain or dramatic symptoms. Instead, the body compensates. It finds ways to work around the problem, at least for a while. Blood vessels might narrow gradually, reducing the amount of oxygen-rich blood reaching muscles and organs. The heart itself might thicken slightly, working harder to maintain the same output it used to achieve easily. From a clinical perspective, this is where things get tricky. Standard blood tests might come back normal. Blood pressure readings might be only slightly elevated, not enough to ring alarm bells. Even basic heart function tests can appear within normal ranges while these subtle changes are occurring. The patient feels terrible, but the obvious markers we look for aren't lighting up red flags yet. This is actually one of the most challenging aspects of cardiovascular medicine. Catching problems during this intermediate phase, before they become acute emergencies, but after they've started affecting quality of life. The fatigue isn't dramatic enough to send someone to the emergency room, but it's persistent enough to significantly impact daily functioning. I've noticed that people often have very different explanations for what's happening to them. Some blame stress at work, others point to poor sleep habits or family responsibilities. Many assume it's depression or anxiety, and honestly, these factors can certainly contribute to fatigue. But what concerns me is when someone has addressed those issues, they're sleeping better, stress is manageable, mood is stable, and the exhaustion persists. There's also this cultural narrative that getting tired more easily is just inevitable as we age. While it's true that energy levels can shift over time, profound fatigue that interferes with normal activities shouldn't be dismissed as simply getting older. The cardiovascular system can function well into advanced age when it's healthy. Significant fatigue might indicate that it's not functioning optimally. In general medical practice, we're seeing more research that connects unexplained fatigue in middle age with early cardiovascular changes. These aren't necessarily life-threatening conditions at the time they first appear, but they can be precursors to more serious problems later. The challenge is identifying which tired patients need further cardiovascular evaluation and which ones are dealing with other causes of fatigue. Blood flow changes can be particularly subtle in women. The traditional heart attack symptoms, crushing chest pain, left arm pain, don't always apply. For many women, the first sign of cardiovascular issues might be this kind of persistent exhaustion, especially if it's accompanied by shortness of breath during normal activities or unusual sweating. Sleep quality often gets complicated during this process too. Someone might be getting their usual 7 or 8 hours, but the sleep isn't restorative. They wake up feeling like they haven't rested, even after a full night. This can happen when the cardiovascular system isn't delivering oxygen efficiently during sleep, even though sleep apnea tests might come back normal. Exercise tolerance becomes another telling factor. I ask patients to think about activities they used to do without much thought, walking to the mailbox, carrying groceries upstairs, playing with grandchildren. If these activities now require significant recovery time, or if they're avoiding them altogether because they're too tiring, that tells me something important about their cardiovascular reserve. This is something many people don't really think about until it becomes obvious. The transition is so gradual that they adjust their expectations and activities without realizing it. They might stop taking stairs, choose parking spots closer to entrances, or decline social activities that involve physical activity. These adaptations can mask declining cardiovascular function for quite a while. The diagnostic process for this kind of fatigue can be frustrating for both patients and physicians. We run tests, and many come back normal or only slightly abnormal. Cholesterol levels might be borderline. Blood pressure might be in the high normal range. Electrocardiograms might show minor irregularities that could be normal variants. The patient feels validated that something is wrong, but also confused about what to do next. From a clinical perspective, this is where experience and clinical judgment become crucial. There are different views on how aggressively to pursue cardiac testing in patients with fatigue, but normal basic tests. Some physicians prefer a watch and wait approach, monitoring symptoms over time. Others recommend more advanced testing like stress tests or cardiac imaging to look for subtle dysfunction that standard tests might miss. The timing of when fatigue appears can also be significant. If someone has been stable for years and then develops persistent exhaustion over a period of weeks or months, that pattern suggests something new is happening. This is different from someone who has always had lower energy levels or who can trace their fatigue to specific life changes or stressors. What I find particularly challenging is that fatigue can be both a symptom of cardiovascular disease and a result of the anxiety that comes from worrying about cardiovascular disease. People become concerned about their hearts, which creates stress and disrupts sleep, which leads to more fatigue. Distinguishing between fatigue caused by heart problems and fatigue caused by worry about heart problems requires careful evaluation. Family history adds another layer of complexity to these situations. Someone whose parents or siblings had heart disease might be more attuned to cardiovascular symptoms, but they might also be more anxious about normal age-related changes. On the other hand, people without family history might dismiss significant symptoms because heart disease doesn't run in their family. The role of other medical conditions complicates the picture further. Diabetes, thyroid disorders, autoimmune conditions, and many other health issues can cause fatigue. The challenge is determining whether cardiovascular issues are the primary cause, a contributing factor, or completely unrelated to someone's exhaustion. Medication effects can't be ignored either. Blood pressure medications, antidepressants, sleep aids, and many other commonly prescribed drugs can contribute to fatigue. Sometimes what appears to be worsening cardiovascular health is actually a side effect of treatment for another condition. Sorting this out requires careful review of all medications and their potential interactions. Lifestyle factors obviously play a role, but not always in the ways people expect. Someone might have excellent exercise habits and a healthy diet, but still develop cardiovascular-related fatigue due to genetic factors, environmental exposures, or other health conditions. Conversely, someone with less than ideal habits might have robust cardiovascular function. The relationship between lifestyle and heart health is important, but not perfectly predictable on an individual level. The social and emotional impact of persistent fatigue often gets overlooked in medical discussions. People start declining invitations, reducing their work commitments, or avoiding activities they used to enjoy. This can lead to isolation and depression, which can worsen fatigue and create a cycle that's difficult to break. Addressing the cardiovascular aspects of fatigue often needs to happen alongside attention to these broader life impacts. These are questions that come up a lot in real life. When to push for more testing, when to accept that fatigue might be related to stress or aging, when to consider cardiovascular evaluation. The answers aren't always straightforward, and they depend heavily on individual circumstances and risk factors. From my perspective, the key is paying attention to patterns and changes rather than absolute levels of fatigue. Someone who has always been a high-energy person and suddenly can't maintain their usual activity level deserves different consideration than someone who has always had lower energy. Similarly, fatigue that worsens progressively over time is more concerning than fatigue that fluctuates or remains stable. The medical field continues to refine our understanding of how early cardiovascular disease presents, especially in people who don't fit traditional high-risk profiles. We're learning that the heart and vascular system can develop problems in subtle ways that don't show up on standard tests until they're quite advanced. This means that persistent, unexplained fatigue in middle age deserves careful attention, even when initial testing is reassuring. There are different views on how to approach this clinically. Some experts advocate for more aggressive early testing, arguing that catching cardiovascular problems early leads to better outcomes. Others worry that excessive testing in low-risk patients leads to unnecessary anxiety and procedures. Most practitioners try to balance these concerns by considering individual risk factors, family history, and the specific characteristics of someone's fatigue. What complicates decision-making further is that many of the tests we use to evaluate cardiovascular function have limitations. Stress tests can miss certain types of heart disease. Echocardiograms might not detect subtle changes in heart function. Even advanced imaging techniques can sometimes miss early-stage cardiovascular problems. This means that normal test results don't always rule out cardiovascular causes of fatigue. The intersection of mental health and cardiovascular health is particularly relevant here. Depression and anxiety can certainly cause fatigue, but cardiovascular disease can also contribute to depression and anxiety. Someone dealing with unexplained physical symptoms, especially symptoms that affect their ability to function normally, understandably becomes worried and potentially depressed. Determining cause and effect can be challenging. I've learned to approach these situations with humility about what we know and what we don't know. Medical science has made tremendous advances in understanding cardiovascular disease, but there are still many gaps in our knowledge, especially about how early disease presents in different populations. Someone experiencing persistent fatigue deserves thorough evaluation, but they also deserve realistic expectations about what that evaluation might reveal. The conversation about fatigue and heart health is evolving as our population ages and as we develop better tools for detecting cardiovascular problems. What seemed like normal aging 20 years ago might now be recognized as early disease that can be treated. But we're still learning about where to draw those lines and how to distinguish between normal aging and pathological changes. This is where a lot of confusion usually starts. The uncertainty about whether symptoms warrant concern and the lack of clear guidelines about when to pursue cardiovascular evaluation for fatigue. Different physicians might approach the same patient differently, and both approaches might be reasonable given the current state of medical knowledge. The patient's own instincts and preferences matter too. Someone who is deeply concerned about their fatigue and wants thorough evaluation deserves that consideration, even if their risk factors don't clearly indicate cardiovascular problems. Conversely, someone who prefers to monitor symptoms over time and avoid extensive testing unless symptoms worsen should have that choice respected, as long as they understand the potential risks of that approach. What I try to help patients understand is that this isn't usually an emergency situation, but it's also not something to ignore indefinitely. Persistent fatigue that affects quality of life warrants attention and evaluation. The goal isn't necessarily to find a dramatic diagnosis, but to understand what's happening in their body and to identify any treatable factors that might be contributing to their symptoms. The timeline for evaluation can vary significantly based on individual circumstances. Someone with multiple cardiovascular risk factors and new onset fatigue might need urgent evaluation. Someone with a low risk profile and gradual onset of fatigue might be appropriately managed with careful monitoring and lifestyle interventions initially, with further testing if symptoms persist or worsen. What I've learned over the years is that each person's experience with fatigue is unique, even when the underlying causes might be similar. Two patients can have identical test results but completely different levels of functional impairment. One person might adapt well to gradually decreasing energy levels, while another finds even minor changes profoundly disruptive to their life. These individual differences matter when deciding how aggressively to pursue evaluation and treatment. The role of communication between patient and physician becomes crucial in these situations. I need to understand not just what symptoms someone is experiencing, but how those symptoms affect their daily life, their work performance, their relationships, and their overall sense of well-being. Someone who mentions fatigue in passing during a routine visit might need different attention than someone who scheduled an appointment specifically because exhaustion is interfering with their ability to function. I've also noticed that people often have intuitive insights about their own bodies that deserve respect, even when objective testing doesn't immediately support their concerns. Someone who says this feels different or something has changed is providing valuable clinical information, even if I can't immediately identify what that change might be. Medical training teaches us to rely on measurable data, but clinical experience teaches us that patient perceptions often contain important clues. The broader healthcare system sometimes struggles with these intermediate cases, patients who are clearly symptomatic but don't fit neatly into diagnostic categories. Insurance coverage for testing can be limited when symptoms are subtle. Specialist appointments might involve long waits for patients who aren't considered urgent. These practical realities affect how we approach evaluation and can influence patient outcomes. From a clinical perspective, I try to balance thoroughness with pragmatism. We can't test everyone for everything, but we also can't dismiss persistent symptoms that affect quality of life. Finding that balance requires ongoing dialogue between patient and physician, careful attention to symptom progression over time, and willingness to adjust our approach as new information becomes available. In the end, the question isn't whether midlife fatigue is always serious. It's not. But it's not always benign either. The challenge is figuring out which cases need immediate attention, which ones need careful monitoring, and which ones can be managed with supportive care and lifestyle modifications. That determination requires careful consideration of the individual person, their symptoms, their risk factors, and their preferences about medical care.